Screening for retinopathy of prematurity. When, why, and how. Retinopathy of prematurity is a blinding disease of premature infants that can be effectively treated if detected early. Early diagnosis of visually threatening retinopathy of prematurity is crucial because the time difference between reversing the condition and saving the vision of the infant or getting a permanent visual affection might be only a few days. The question is which infants are at risk for getting a retinopathy of prematurity. Retinopathy of prematurity is a disease of premature infants and or those of low birth weight. The risk of the condition increases as the gestational age decreases and as the birth weight decreases. Several other factors might increase both the risk and the severity of retinopathy of prematurity, such as exposure to high oxygen saturation in the NICU, intraventricular hemorrhage, respiratory distress, neonatal sepsis, as well as twin pregnancy. Now, which infants need screening? In countries of high socioeconomic status, usually it is recommended to screen any infant born before 31 weeks and those with a gestational birth weight less than 1,500 grams. In countries of lower socioeconomic status, usually these parameters are lowered down so that we screen any infant with birth weight less than 200 grams and those with gestational age less than 34 weeks. We recommend that we screen infants in African countries in case the birth weight is less than 2,000 grams, if the gestational age is less than 32 weeks, and if there is an unstable clinical course. When to screen? According to the CRY-ROP and the LIGHT-ROP studies, the more premature an infant at birth, the longer the time to develop serious retinopathy of prematurity. The onset of serious retinopathy of prematurity correlates better with post-conceptual age. The post-conceptual age is equal to the gestational age plus the chronological age of the infant. According to most academies and ophthalmological societies, it is recommended that the time of the first examination should be at 4 weeks of chronological age or at 31 to 32 weeks of post-conceptual age, whichever is later. This is a table showing the time of the first examination according to the gestational age of the infant. Now, where and how to screen infants? Infants can be screened in the neonatal intensive care unit as well as in the outpatient clinics. For proper screening, you need ophthalmic instruments in order to examine the posterior segment of the infant, as well as a dedicated team. This team should include a keen neonatologist, a well-trained ophthalmologist, and nurses that can follow your system. The instruments required to examine the posterior segment of the infant include an indirect ophthalmoscope, a 20 and preferably a 28 diopter lens, a speculum, and a scleral indenter. You should need to raise the awareness and interest of neonatologists. Neonatologists should recognize infants at risk, should ask for screening for retinopathy of prematurity for infants at risk in the NICU, and should instruct the parents of at-risk infants to have their eyes timely examined. Nurses are usually required to put dilating eye drops for infants before examination, to assist the ophthalmologist during examination, and to recognize any neonatal distress during examination. And definitely, you need a well-trained ophthalmologist in ROP screening. They should also recognize the importance of the screening and spread their knowledge to younger generations. The steps of examination: you need to put an anesthetic drop first. In addition, pain can also be minimized if the infant is sucking or using pacifiers or sucrose. You can also use swaddling in order to minimize the movement of the neonate. Use a sterile speculum to open the eyelids. Examine the posterior pole with a 20 diopter lens to look for plus disease. Then examine the periphery of the lens with a 28 diopter lens to get a better view of the retinal periphery. You need to examine all quadrants of the retina: the temporal, nasal, superior, and inferior. You should start from the center and go all the way to the ora serrata. You need to indent the sclera using an indenter for all peripheral retina in all 4 quadrants. And the indentation should be as gentle as possible to avoid vascular occlusion and dampening of vascular signs. During examination, you need to move 180 degrees around the neonate in order to get the full view of the whole retina. Wide field fundus cameras, for example RedCam, can also be used. However, they are a bit expensive and are not readily available in all places. Now, how frequently should screening be performed? A higher stage and a more posterior zone requires a more frequent screening. So, for example, if you have a plus disease or a disease in zone 1, you need to examine the infant once or even more than once each week. If the disease is in zone 2, you need to examine the infant every 2 weeks, while if the disease is more peripheral, you need to examine the infant every 3 weeks. Now, when can screening be concluded? In the absence of previous retinopathy of prematurity, we can stop screening when the vessels reach zone 3. On the other hand, if there is previous retinopathy of prematurity, you need to wait until there is full retinal vascularization. Thank you.